Hello, everyone. Nice to meet you all, and thank you for giving me this opportunity. It's a really honor, and I'll try and do my best to answer some of these questions.
Can you tell me if FAVA could be accurately diagnosed just with a physical exam and an MRI, or do you suggest that patients actually go and get a biopsy in order to confirm the diagnosis?
Pain and disability are almost always present with FAVA, and these symptoms can be pretty non-specific, for which some sort of cross-sectional imaging, and most commonly it's an MRI that we rely on, will help to delineate the anatomical location and also certain radiological morphology of the lesion. And based off these, and also the center's or the individual physician's experience, the diagnosis can be reasonably made. Now, occasionally, when symptoms or some of these radiological features are very atypical or unusual, that's when we recommend doing a biopsy, and we do them occasionally. There was a time when we used to do them frequently in the beginning of our experience, but then since our experience has grown significantly since then, we don't perform as many biopsies. We are comfortable calling them just based off the physical exam and the MRI features.
Okay, perfect. And you are an interventional radiologist and you do cryoablation on many FAVA patients. Can you walk me through the procedure of cryoablation?
The cryoablation of cryotherapy is important to understand what it is. It's basically a process of freezing an abnormal tissue. In this case, we are talking about FAVA, but this technology is not very novel or very new, but obviously the indication of using this in malformation is pretty new. If you look at the malformation, which is FAVA, the malformation itself has replaced a part of the muscle or the entire muscle. So this is bad tissue, and this bad tissue is identified using MRI imaging initially, and then when a diagnosis is made or after biopsy confirmation is made, you bring the patient in for the procedure. Most patients are under general anesthesia so that they're not moving and they're comfortable during the procedure. And the bad tissue is identified using ultrasound scanning, and using the scanning technique, these cryoprobes are essentially needles that are placed precisely within the bad tissue or around the tissue in a way that the conformation of the ice ball that forms later, it kind of encroaches the malformation completely and then freezes the tissue. And it's also important to be able to protect the tissue surrounding the malformation in order to minimize damage to these structures. This is in brief how the cryoablation technique is performed.
Okay, and when you say bad tissue, what do you mean by that?
That's the tissue that's been affected by the malformation.
And do you ever do sclerotherapy on FAVA patients?
Now, sclerotherapy should understand is a commonly performed procedure for vascular malformation, and some centers and some people still continue to use it for FAVA. Now, unfortunately, when used alone, sclerotherapy does not provide any long-term relief, and patients often relapse with worsening symptoms. Now, however, it can be used as a combination treatment with cryoablation to help synergize the effect, and not recommended as a solo treatment only. So I do use it not by itself, but to just help the cryoablation procedure. If there are big veins and big vessels that need to be closed at the same time, I will use sclerotherapy. I also use embolization to kind of close down those bad vessels.
Can you define sclerotherapy and embolization?
Well, yeah. So the process is slightly different, but the goal is the same. Essentially, sclerotherapy means injecting medications into blood vessels to close them down from within. It creates an inflammation of the vessel walls from inside, and then over a period of time, these vessels shut down. Embolization is physically putting in agents that kind of clog the blood vessels and not let the blood sit there, or does not let new blood get into the open veins. Now, again, the terminologies are different. The indications are slightly different. For bigger blood vessels, or these are more technical details, but for bigger blood vessels, we tend to use embolization more than sclerotherapy. But essentially, this is to reduce the volume of the blood vessel space in the region of the malformation.
And is it possible that a patient would get cryoablation with you or resection and then later need sclerotherapy?
Typically not. I try to combine everything in one session, sclerotherapy and cryoablation together, or sclerotherapy, embolization, and cryoablation together. It's better for the patient experience as well, and it's better for assessing the outcome as well. And that also reduces the number of anesthesia sessions. So we generally try and do it in one session.
Were you the first person to do cryoablation on FAVA?
There was some experience on venous malformation, very limited malformation in Europe, which was like on 4 patients or so. But the real experience of doing cryoablation was from here. I probably did the first one based off some experience, but I was using this modality to treat some cancers, and I know how it works. Which is why I thought it will be a good option in some of these difficult malformations. So we had a proven case of FAVA in whom we treated this and found it to be beneficial. That's how I started using it.
And what made you think it would work based on what you saw in cancer?
Just the science behind it, as I mentioned. We were kind of go a little back in the past. We were reviewing a patient in one of our weekly meetings, and this was very early on in my experience. When I was listening to the discussion, there was a few discussion about amputations and considering amputation as an option, which I thought was a little on the severe side. That's when I proposed, if that is the case, we should at least try something less invasive than that. If it works for the patient, that'll be great. We'll be able to save a limb. Don't have to worry about an amputation. So that's how I thought about it, but I had the science behind it. I knew how it will work, and I was hopeful that it will work in the same manner.
And you said you've made advancements so far in your practice. Do you have any examples of where you were when you started in 2012 versus where you are today?
Well, when we started, obviously, we had rudimentary knowledge on how the patients will recover, what to expect after the procedures. The tool that I had was I knew the science and I knew how to use it, but I didn't know a lot of answers to the question. So we learned a lot during this journey. I especially learned a lot, and I learned a lot from my patients too. And since then, we have been very good at managing the pain after the procedure, of using nerve protective mechanisms, of protecting the skin during the procedure, of not using a lot of radiation during the procedure. I tend to use only ultrasound most times, and being very quick with the procedure. So there's several things that have changed over a period of time, and over all these years, the procedure has become extremely safe and effective. I've also started doing some sclerotherapy, which has this generic term called cryosclerosis. Again, I started trying this here for the first time, and I've observed a lot of differences in early recovery in those patients, and which is what I'm doing.
And what should a patient expect following the cryoablation?
So following cryoablation, most patients experience some sort of swelling, some soreness, occasionally some bruising at the treated site. This will gradually improve over 3 to 7 days with appropriate rest, some anti-inflammatory medications, and limited weight bearing.
When should they expect to know if the treatment worked?
Now, that may depend on several factors, but on an average, most patients start experiencing or appreciating some changes by 3 to 4 weeks after the cryoablation is done. Again, it all depends on the location of the malformation. Sometimes they're in difficult spots, the extent of involvement, but the typical ones, which are focal in the calf muscles or in the thigh muscles, those kinds of malformations typically start showing response within 3 to 4 weeks.
And where are difficult spots?
There are certain difficult spots, such as the foot. They call the intrinsic muscles of the foot, or sometimes if they are in compartments where there are critical structures like nerves or blood vessels or around the joint or some of it extending into the joint. These are some challenging areas to treat.
Once cryoablation is done, do patients need physical therapy afterwards?
That's again a great question, and I cannot stress enough the need for doing physical therapy afterwards. Now, physical therapy helps to improve the mobility by releasing the muscle spasms and the contractures, which are inherent with these lesions. It also helps improve the muscle strength, which is generally weak in the affected limbs. Now, 8 to 10 physical therapy sessions, usually over 2 to 3 months with a therapist, is what I recommend. But it's not always possible in many situations. So I encourage patients to procure kind of the instruction sheet for home exercises, which reduces the visits to the PT clinic and obviously the insurance costs. After that 3 month period, I always again encourage and advise patients to continue doing at least 10 to 20 minutes of PT or stretching at home. In my experience, I've seen patients who continue doing PT at least 2 to 3 times a week. They have for a longer duration, anywhere between 6 months to a year, or make it a part of their lifestyle. They tend to have longer and better outcomes with muscle movement and going back to the activities especially athletic activities.
Let's say they do physical therapy for their 3 months. Maybe they do it at home for a while and then they stop. And then after a certain number of months or maybe years, their pain starts to come back. Is it possible that if they start doing physical therapy again, that would resolve the issue, or probably not?
That has happened in the past, and I've had a few patients who have done that, who have abruptly stopped physical therapy or have been disinterested in doing physical therapy, and the pain has recurred. And before we propose any other treatment, it's always good to go back on physical therapy and try that. And a number of patients have found relief doing that and have not had to repeat any procedure.
If they're in an area where you can't treat the entire mass, is it possible to treat part of the mass? Would that have any symptom relief?
Yeah, no, that's a great question, and I often do that. And you have to remember that this is not a tumor tissue. So this is not a tissue that is going to grow exponentially or that needs to be taken out of the body. This is patient's own tissue, which has grown bad. It did not form the way it should have been formed. That's why we call that as a malformation. And it's not necessary that we try and treat or over-treat this lesion in order to completely sort of do a surgical kind of cleanup. You can, even if it's a large lesion, sometimes there are patients who have areas within a part of that malformation, and the entire area is not tender. So we can pretty much tailor down such areas and custom treat just that area so that so as to control the pain or the symptoms. So if there are large areas, if there are parts that go into critical areas, then you don't necessarily have to go into those areas. You may be able to get away by treating portion of the malformation. And if that provides them pain relief, that's pretty much it. Then you don't have to treat more than that.
And is it possible for those people to get as much pain relief as people that are in a better spot, like a calf, where you could treat the whole mass?
Most times they do. If it's in a spot which is painful and away from a critical structure, and if you just address that, you get good pain relief. And if there is any minimal pain which is left over, they can occasionally they take pain meds, and it does not interfere with their daily activities, and you continue to work through that.
With the cryoablation, you're not removing the whole mass, you're just freezing off the bad tissue. And so you are getting pain relief just by freezing off that bad tissue, correct?
That is correct. In FAVA, there are several factors that actually contribute to the pain. These include like bad muscle tissue or abnormal blood vessels which are sitting within the malformation. And there is a lot of tissue scarring that is there within the FAVA malformation. And sometimes there are bad nerves which actually are in and around the malformation. And all of these actually contribute to the pain. Now, to alleviate that pain, all these components need to be treated. If you're just treating one component of it, then you will not get the relief that you're looking for, the expected results.
How do you treat bad nerves?
So the nerve, I mean, if you look under the slides, there are good papers that has been written about this before. And when the FAVA actually, or this kind of malformation affects part of the body, everything that is there in that particular zone gets affected, like blood vessels, nerves, the muscle fibers. So these are components of that malformation. It's not just bad vessels. When you talk about vascular malformations, as the name is suggestive, it is not just vessels, as it is with most other malformations. Here, even the tissue around it is abnormal. So that's where the nerves component come in. So there are pretty bad nerves. They are hypertrophied, they are thick nerves, and they're very painful. That's why some of these patients suffer with neurogenic pain. So it's important to kind of freeze and take all of these components out. Although you're not physically taking this malformation out, it's made inactive or dormant by freezing. It's like the same analogy that I gave you. It is like having a bad child that always stays with you. You just have to learn to manage it.
Can you talk about possible and probable complications from cryoablation?
So cryoablation is a very well tolerated and a safe procedure, especially when it's performed by experienced physicians who are very familiar with the technique and what to look for and what to treat. Now, rarely inadvertent skin or nerve injury can occur when these structures kind of lie in close vicinity of the area that is being treated, or like when I was mentioning prior, when the nerves are entangled inside the malformation. Now, most patients again feel numbness, which is the most common side effect and not a very serious side effect. And more serious side effects like permanent nerve damage, like foot drops or complete loss of function, are extremely rare. I have not seen that in my experience. Patients who have had foot drops or weaknesses, that has always been transient and temporary. I've always seen it recover. So it's never permanent damage in my experience.
And what is foot drop?
Foot drop is a nerve damage that can happen because of one of your nerves in the calf area. You're not able to elevate your foot, extend and flex your foot.
If they experience numbness, is that forever or is that temporary?
That also gets better with time. It takes a little longer to go away completely. Now, again, when I say numbness, not all patients not all patients really dislike that because of the fact that FAVA being a very painful condition, some of these patients have very hypersensitive skin to an extent where I have met a few who are not able to wear their clothes or not able to pull a sheet over them when they're sleeping because it's so sensitive. So they actually like the idea of or they feel better when there is numbness in that area. But again, it's not a permanent thing. It gets better. It may not, depending on how much has been ablated or how big the malformation is, you may not regain complete sensation. It takes years for that to happen. Also depends on the age of the patient. At a younger age, the patients have more plasticity of growing nerves, and they may be able to get back to normal sensation sooner than the older individuals.
And for nerve damage and foot drop, if someone experiences that, you said it's temporary. Do you have any type of time range for how long that would last for?
Yeah, again, when I say that, this is out of my own experience I'm speaking. It also depends on how the damage has occurred. If you go through a nerve or if you injure the nerve directly, then the damage can be permanent. But if it is nerve that has shown some signs of damage because of the cold which was there in the vicinity, then the nerve will recover its function. And that can range anywhere between 3 months to 6 months. Some of them can regain function within 3 months. Some of them can take a little longer, but they may need some physical therapy, definitely physical therapy to help with that.
Do you know, out of the people who did have at least partial, if not total pain relief, what percentage approximately had recurrence later?
Now, recurrence generally is between 5 to 10%. And when you say recurrence, it's mainly pain. And again, it's due to several factors, like coming back to, again, the location, chronicity of symptoms, inability to treat the lesion entirely because of where it's sitting, or if patients have not adhered to a PT routine. Typically, up until 3 months or so, we don't really say that we have completely evaluated the response, or we would know the full extent of the response up until at least 3 months now, because we have seen some late responders where patients gradually improve over a period of 1 to 3 months, and then they kind of peak and they feel better. So we don't recommend, or I don't recommend them to get another kind of treatment or a repeat treatment in the first 3 months. So typically the recurrence, I would call them, I would label them as recurrence if the pain has been out for a few months and then comes back, and which in my experience is anywhere between 6 months to 2 years.
Is it safe to say if they've gone 2 years without pain that they're looking pretty good?
Most people have.
Is your answer to that different if you were only able to freeze part of the lesion, you couldn't get to the entire mass because of the location?
I'm going back to what I was saying before and alluding to before. This is not a tumor, and you don't have to treat all of the malformation to be able to achieve your goal, which is taking away the pain or the ability to improve their lifestyle. So it's a decision that is based off experience of that physician who has seen a lot of these lesions, has treated. So in my experience, that is what I have found. It is not essential to treat all of the lesion. I've in a few situations, I've had to leave some part of the tissue, and patients are doing great without having touched that part of the tissue at all. And I've not had to go back and treat them.
And so let's say you have a patient that comes to you and you and Dr. Spencer decide that they qualify for cryoablation and they qualify for resection. Which one would you suggest that they do?
Now, that's a great question again. Now, when a treatment option, and it's a great thing that there are so many options available. When a treatment option is discussed with any patient, obviously you want to know more about the benefits, the recovery, the follow-up, and the risks that are associated with every treatment. Now, at our own center here, the patient gets an opportunity to meet all the specialists involved in FAVA care and discuss these items and make a well-informed decision. Now, as far as cryoablation is concerned, it is a low-risk, minimally invasive procedure with a very fast recovery time and has shown excellent outcomes in our experience. So I present that part, all the experience that we have had in the past, to the patient, and then obviously Dr. Spencer also weighs in, and she proposes what she could do. And if there is a medical treatment, the same applies. At that point, it's a little bit of a decision that the patient or the family then decide which one is better for them, which one they want to go with. In my experience, most people obviously want to go in for a minimally invasive procedure, and if it's equally good or better, that's what most people go with, and that's why we do a lot of cryoablation as a primary treatment in many patients. The nice thing about doing it that way is it doesn't take away your option of doing a surgical resection later. So you can still reserve a more invasive procedure if we have to go that route to a later date. But luckily, unfortunately, that has not been the case in many patients.
And what if they decide to do a resection first and then it doesn't work or the pain comes back? Is there then an option to do cryoablation, or did they take that off the table when they did the resection?
Absolutely not. And it can be easily done. I have done several of those where the pain has come back or the malformation has grown at the peripheries or in sites that were not completely removed because of some reason. If the pain recurs, I've had to go in and treated those areas again with good outcomes. But it can make things a little bit complicated in trying to understand the physiology and the pathophysiology behind pain, because pain is a very complex phenomena, and it's very difficult for people to kind of equate the pain. It may be very different in different people. So the pain that comes after surgery can be complicated by the surgical scar itself that can happen after surgery. Sometimes there are other structures that are sacrificed during surgery that you're not aware of, and that can complicate, like nerves can be taken away during surgery, and then you can have neurogenic pain, and those are difficult to treat with any treatment. It makes things a little bit complicated, but it can still be done, and we have done a few of those as well. Yes.
Do you have an opinion as to whether the FAVA is more likely to grow back after resection or cryoablation?
Yes, this depends on several factors. Now, again, such as age of presentation. I mean, younger patients can have increased growth of the malformation during puberty, and if the malformation was undertreated for some reason, as opposed to adults in whom the ability to grow tissues has already reached its zenith. So it again depends on several factors, but there is a likelihood that they can grow from the edges of the treated areas with time.
Do patients ever have to take medication like sirolimus or alpelisib after cryoablation?
That's also a great question. Now, FAVA, it is associated with very, very complex symptoms. It's very difficult to discern the symptoms and correlate with what we are seeing on imaging. So, and it involves body planes and structures that are tough to treat with cryoablation or even resection for that matter. Now, these medications can be tried in such patients. It is not ideal, or it's not necessary to take medication after the ablation for every patient, at least until the complete effect of the ablation can be thoroughly assessed and then dismissed saying this didn't work. But we don't typically put patients on medications after ablation at all.
So it sounds like it's unlike resection, where Dr. Spencer said she could probably tell in advance who she's going to do a resection, and then they might need medication later. This is different.
Most times, yes, because it depends on which kind of patients are you accepting to do cryoablations on. So if your patient selection, based on that, you can tell, yes, the cryoablation is going to work here. Most times it will. If it is not the kind of patients who are ideal for cryoablation, then they shouldn't go for cryoablation. They should go straight away for resection or try medical treatment.
If you do cryoablation and the person seems symptom-free, how often do you suggest that they check in with their doctor or they go get an MRI?
Great question. And every center and every physician probably has developed their own protocol. I can share what I do with these patients. The way I follow these patients is after cryoablation, I see them a month later to assess their symptoms, and if I feel they're doing well, they're going to do physical therapy, and we bring them back 2 months later from then, or 3 months from the time of the procedure, to reassess and document the progress and the improvement. And we'll have another follow-up at 6 months and 1 year, and then it's yearly for the first 3 years if they can. Most patients, because they have relief at the end of whatever, a year or so, they choose not to come back, or they choose to come back as needed. But it's really not necessary to have them get frequent MRIs. It's mostly a symptom-based follow-up. And based on evaluation, when they come back for a visit, if there are symptoms or recurrence, if we think there is need for MRI, then we repeat an MRI. Most times this decision can be made just with ultrasound that is performed in the office.
Do you have a list of questions or suggestions that a patient should ask their doctor before going through with cryoablation?
Well, if I were the patient, I would definitely want to know their experience in diagnosing and treating these conditions, and what's their follow-up regimen, and the kind of questions that you just asked me. But my foremost questions would be experience in diagnosing and treating this. I would also want to know and meet other specialists who can take care of this, or who have other options to offer. So it's important to have that information as well. because some part of the decision lies on the patients or the family when it comes to A versus B or versus C, choosing that kind of an option. So I would want a center to go to a center which has a lot of experience first diagnosing and treating this conditions with different specialties.
Now, what if you diagnose a patient, but they don't have any pain or other symptoms, or they're not that bad, it's not stopping them from doing anything? They're not ready for any type of procedure yet. Do you suggest they come back every so often or a certain amount of time to get an MRI or see a doctor, or do you just suggest that they come in when it's actually needed?
It's better to treat it when it is symptomatic, and not treat it if there are no symptoms. It is not a tumor; it's body's own tissue. You can just follow it up, come back when it is symptomatic.
Now, I know you see a lot of patients that do not live in the Boston area. So let's say someone wants to go to Boston and have you observe them and potentially get cryoablation. Can you walk me through the process of how that works from the time they make the appointment until they get the cryoablation done?
They would be seen in the vascular anomaly clinic at a center, and they will get a chance to meet everybody, including myself. And if they decide to pursue cryoablation, then they will be given instructions and details. One of our schedulers will call them with the date, and they will give them a few options so that they can work out a convenient time and date to get the procedure done. The procedure typically is anywhere between 2 to 3 hours. It's a day procedure. They'll get the procedure done. They'll be observed for a couple hours in the recovery, and they'll be able to go back to the hotel or back home if they're local. Some families, they like to stay for a couple of days in Boston, just in case if they're flown from other places. But if they're local, we send them home the same day.
So if they're from out of town, they potentially can go from initial diagnosis to actual procedure in one trip without having to come back a second time if they want to.
Not necessarily. If we already know a lot about the patients, sometimes these patients are reviewed at our weekly conferences, and based on the imaging, if we have looked at it and we have made a reasonable diagnosis of FAVA, then we can do that where they can come directly. A procedure will be scheduled, and they come in, and in one session everything will be done. But let's say if the diagnosis is not clear and there's some information that's missing, in which case they'll have to first come in for a clinic visit with us. It may be a month or two before they get to me for the ablation.
What if they cannot get to Boston? They have been diagnosed with FAVA. Let's say even you guys already reviewed their case and gave a second opinion in your weekly conference. Do you have a program where their medical providers could talk to you and ask questions?
The best way to do that is to get in contact with our VAC team, and there are our NP liaisons are really great. Once they reach out to them, they will be able to find the right physician to whom these questions can be addressed, whether it is medication related, whether it's cryoablation related, or whether it is surgical related. They will get these questions forwarded to that particular physician, let them answer. Now, sometimes it's always there are patients who reach out like that. There are some physicians who reach out like that. But at times, it's difficult to share all that information on a paper. So if we feel the necessity to schedule a virtual visit with the patient or the family, then we can do that. Now we have the ability to do that on the Zoom. We offer virtual visits, so we can meet with them and provide a second opinion face to face. And if they have a physician who wants to be in touch with us regarding management options, then we can help them out too.
And let's talk numbers if you know them. Do you know how many FAVA patients have been seen by your Vascular Anomaly Center?
I'm not exactly certain of that number, but we do have a huge experience seeing and treating these patients.
Okay. And do you know how many cryoablations you've performed?
I would think close to 100, but I've stopped counting.
Do you know approximately what percentage or what numbers out of the people who have had it, how many have had total pain relief versus partial versus no effect at all?
So in my experience, more than 80 to 85% of them have had total relief. Few of them have had partial but observable and appreciable response, not needing any treatment. And about less than 10% of them have had no response, for which we have done resections or put them on medications.
And the people that had no response, did they have something going on that you could have known beforehand that they might not respond?
Yeah, that's a great question. FAVA is a complex malformation, and sometimes the size of the lesion is completely disproportional to the symptoms that patient has. So these patients have to be evaluated thoroughly, assessed. The MRI images or the cross-sectional images have to be looked at and correlated with their symptoms. And it is important to know the chronicity, how long the symptoms have been on for. All these things kind of make that important on whether these patients are going to respond to the treatment or not, and what is the best treatment. For example, the location, if it's close in compact areas like the foot, or if it's around the joint, or if it's a very diffuse lesion and the patient has very discordant symptoms, his or her pain is not right on the area of the malformations. So it's hard to tell that this sort of a treatment is going to help them. So it's a process. It's a process, and that's why evaluating these patients in a multidisciplinary vascular anomaly care center makes so much sense.
What type of improvements do you predict we will have in terms of cryoablation on FAVA patients?
This was an off-label use of this technology, but has found immense implications in the field of vascular malformations. I think has made a huge difference in so many patients' lives and their daily activities, especially the kids. I've had several kids who have gone back to full level athletics, people who have gone back to hiking and mountain climbing after ablation. So, and I'm very happy to also know that a lot of centers now are offering this as a means to treat FAVA. I'm sure there is more streamlining and finessing the technique by every individual. Medicine is all not science; it's also art of healing. So every individual may do it slightly differently, but there's a technology. There's proof of concept that it works. So I think it will keep getting better. Within my own practice, I have made a lot of changes over the years. When I first started doing this, from the time when I first started doing this, which was in 2012, to now, there have been a lot of changes in the protocols. The way I think about this and treat this has changed. But I do have like a skeleton foundation and a baseline framework that I use. But there are variations in some techniques and using protocols. I'm very hopeful that we'll see more and more finessing of this technique, and we happen to learn about these at a lot of interventional radiology meetings where people have started doing it for malformations.
Do you think if there's a FAVA patient who doesn't qualify for cryoablation today, or maybe they didn't qualify 5 years ago, that there's hope that in the future maybe they would qualify for it?
Probably, but also there's so much research being done on the medication side, and I'm hopeful that there will be more medications that will be discovered, because the pathway, people are understanding the pathway much better, and it's always better to treat it with completely non-invasive treatment than to have any sort of invasive treatment. So I'm hopeful that there will be more medications and pills in the coming years, and we may not have to do so many invasive procedures on these patients. Also, when they're diagnosed early in life, maybe we can start to give them these medications once we know they are safe to be given.
Do you have any final thoughts or final words of wisdom for the FAVA patients?
Well, I wouldn't say wisdom, but I'm look at the brighter side and say it's great to have so many options and talk about it and know so much about something that was so obsolete and nobody knew about it. Even like 10 years ago, it was completely mislabeled into the wrong category, wrongly treated, and patients have suffered for years. But now, with all these options and so many centers having the ability to treat that, is great news for all the FAVA patients. So I'm very, very, very hopeful, and I like the positive part of it.